We'll now move on to our first session. This is the academic session 1, breast cancer and cardio-oncology. And this session is supported by Zydus and Eli Lilly. It gives me great pleasure to introduce our chairperson, Dr. Vijay Prakash Pandey, senior consultant, cardiologist from Narayana Super Speciality Hospital, Howrah. I welcome sir to please come to the stage and introduce our speakers.
Good morning, everyone. So we have got two speakers on this panel now. One is Dr. Ashish Upadhyay. We'll start with him. He'll be talking on a CDK4 and 6i cardiotoxicity focus. And that will be followed by Dr. Rajiv Bhattacharya, who will be dealing with anti-HER2 treatment-related cardiotoxicity. We'll start with Dr. Ashish Upadhyay. Please come on the stage to share your presentation.
Good morning, everyone. First of all, I would like to thank Vivek sir for inviting me here. So basically, I'll be talking about CDK4/6 inhibitor and cardiotoxicity, where I'll be discussing 3 studies. This talk is sponsored by Lilly. So the first study, the Mayo Clinic study on atrial arrhythmia with CDK4/6 inhibitors. So basically, the background, we all know CDK4/6 inhibitors has been a very integral component of the treatment for hormone positive, HER2 negative breast cancer patients. And emerging data suggests there is arrhythmia, but the incidence is not known. Now with the integration of CDK4/6 inhibitors in adjuvant setting, the incidence becomes even more important. So, this was a retrospective study from Mayo Clinic from the year 2015 to 24. Total 2,782 patients of hormone positive HER2 negative breast cancers were included on CDK4/6 inhibitor. If you talk about the drug, the maximum was palbociclib in 59% of the patient. Then it was abemaciclib in 28%, and ribociclib was given in only 14% of the patient. So the primary endpoint was new onset arrhythmia. The secondary endpoint was stroke and all-cause mortality. So if you talk about the overall cumulative incidence for 5 years, it was 2.8%. If you go by the drugs, the maximum was with palbociclib, because we know the real world use is more with palbociclib. It was 3.2%. Next was abemaciclib with 1.7%, and ribo was almost same, 1.1%. So there was no significant difference among the agents. So on multivariate, if you talk about the risk factors on multivariate analysis, only age was projected as an important risk factors for arrhythmias. Hypertension and vascular disease were significant in univariate analysis, but were not significant after adjustment. If you talk about stroke, then 4 patients, that was around 9.5% of those patients with arrhythmia developed stroke within 1 year. 2 were anticoagulant, 2 were not because of contraindication. So the highlight being anticoagulant assessment is important in those patients on CDK4/6 inhibitors who develops arrhythmia. If you talk about the overall mortality, the 5-year all-cause mortality was 41.2%. New onset arrhythmia increased mortality by 56%. So arrhythmia may reflect systemic inflammation, disease burden, or even cardiac remodeling effect. And the clinical implications, so TDK4, they are associated with low but clinically significant arrhythmia. Age is being the most important as per the finding. Drug was not. Arrhythmia increased even the risk of stroke and also the mortality in those patients with stroke. So baseline ECG, risk stratification, early cardiological input advised for older patients and those patients with comorbidity. So this, of course, this study had limitations, the major being the retrospective design. Along with that, we know in retrospective studies, there is potential underreporting of the data as well. There was no control group, but still this is the largest real world data that we have on this topic. So the key takeaway is arrhythmia with CDK4/6 inhibitor is uncommon, which is seen in around 3% of the patient, but it is clinically significant. Older patients, they are at more risk, and new onset arrhythmia, they are independently associated with those patients with either increased age, that is around 65 and beyond, and those with comorbidities. So next study is on cardiovascular toxicities with CDK4/6 inhibitors. That was insight from meta-analysis and FAERS database. So the background, again, we all know CDK4/6 inhibitor are keen hormone positive, HER2 negative breast cancer patient. There is emerging evidence which shows potential cardiotoxicities, but we have limited data on incidence and specific patterns. So the overview, the study included meta-analysis with 17 randomized controlled trials with a total of 23,437 patients, and it also included FAERS database from the year 2013 to 2023. So the aim was to quantify and characterize the cardiovascular events linked to CDK4/6 inhibitors. And this study also had comparator arm. The two arms were CDK4/6 inhibitor with endocrine therapy versus endocrine therapy alone. So the overall cardiovascular risk was around 1.86 times higher with CDK4/6 inhibitors. If you talk about the common events, cardiovascular events per 1,000 patients, the maximum was hypertension in 68 patients. Next was QT prolongation in 57 patients. Then DVT in 17 patients. Again, fibrillation 2.5 and myocardial infarction in 1.7. So again, severe adverse events was also increased by an odds ratio of 1.87. If you talk about drug-specific finding, we all know ribociclib, it has the strongest association with QT prolongation and also with acute coronary events. Abemaciclib, it is linked with higher risk of DVT and embolism. And palbociclib, they have milder cardiovascular profiles. Some reports of lymphedemas are there. So the pattern and stage, it is also seen that the risk was higher with metastatic patient as compared to adjuvant setting. This is mostly because of the patient distribution, because we know advanced patients, they are elderly, they are associated more comorbidity. So mostly it is because of the baseline patient characteristic. There were severe cardiovascular adverse events when combined with either aromatase inhibitors or fulvestrant. And FAERS database, palbociclib was responsible for 91% of the use, which shows the global use of palbociclib. Mechanism involved, to say that for hypertension and myocardial infarction, mostly it was cytokine-driven inflammation. Responsible agents were interleukin-1, 6, TNF-alpha. For QT prolongation, it said that ion channel gene modulation, the genes involved is KCNH2 and SCN5A. Thrombosis, we all know cancer-associated hypercoagulability, and also the CDK4/6 inhibitor, they also alter few of the pathways responsible for platelet. That also leads to increased risk of thrombosis. So the clinical implications, CDK4/6 inhibitors, they raise the risk of multiple cardiovascular adverse events, mostly are mild to moderate, but they are clinically significant. Ribociclib needs ECG monitoring. Abemaciclib, we should be cautious in those patients with thrombosis who are prone to thrombosis. And so emphasis should be on baseline ECG, BP control, and cardio-oncology referral in those patients who are elderly or with multiple comorbidities. Strength of the study was, again, largest randomized control data, also including FAERS database. So it had both real-world and trial-based approach. Limitation, we all know randomized control trial, they underrepresent cardiac morbidity because of decreased reporting of that. And FAERS database, they have voluntary reporting bias as well. So the take-home message is CDK4/6 inhibitor increases the cardiovascular adverse risk to twice, including hypertension, QT prolongation, thrombosis, atrial fibrillation, and myocardial infarction. Ribociclib shows the highest cardiac signal. Abemaciclib is linked with thrombotic events, and the need of cardiac surveillance and multidisciplinary management, especially for elderly patients and those with multiple comorbidity, is important. Now the third and the last study, abemaciclib and venous thromboembolism in breast cancer patients. So again, the background, CDK4/6 being an integral component of hormone-positive, HER2-negative breast cancer patient. So there is emerging safety concern of venous thromboembolism with abemaciclib. The FDA has also even a black box warning for that. So again, the primary objective of the study was to assess thromboembolism risk with CDK4/6 inhibitor, which took into account meta-analysis, real-world data, as well as FAERS database. So, and also to explore the biological mechanism behind it, if it is because of the platelet or coagulation assay. So this study included randomized trial, control trial of 13 trials, including 16,903 patients, real-world studies of 9 cohorts, including 6,490 patients, and database, FAERS, PubMed, and Embase. Lab works like platelet aggregation, P-selectin, and coagulation was also assessed. So the key result is we can see the overall embolism risk with CDK4/6 inhibitor is more as compared to the control arm, that is 2.1% versus 0.7%. The odd ratio is 2.7. If you go by the age, and abemaciclib was associated with the highest odd ratio, 4.4, then palbociclib 2.35, and ribociclib, it was not significant. So if you talk about the real world data, that was the RCT, randomized control data. So if you talk about the real world data, we know that real world patients, they are associated with higher disease burden, elderly age, more comorbidity also. So the real world data shows that embolism risk was even higher, twice as compared to the RCT, 2.1% versus 4.2%. If you talk about the retrospective thrombotic focus studies, the incidence was even more, 5.5%. So we can see the higher rates as compared to randomized controlled trial, which can be mostly because of broader population and sicker population. So if you talk about the odds ratio, again with abemaciclib, it was 1.63, ribo 1.17, and palbociclib, there is no signal. So median time to the event was 84 days after initiation, and around 11.9% of cases were fatal. So mechanism involved, abemaciclib enhances platelet activations, especially agonist that is collagen pathway induced. There is no effect on coagulation parameters. Fulvestrant co-administration did not further increase the activation. So the clinical implication is, of course, it's very important to monitor those patients with high risk of venous thromboembolism, like those with previous history of embolism, elderly, non-ambulatory patients. So it's very important to consider baseline risk assessment, though Khorana score may not apply because that is because of cancer-induced thrombosis, and here we are talking about drug-induced thrombosis. So it's very important to educate your patients for early symptoms of these venous thromboembolisms. So the take-home message is abemaciclib has highest venous thromboembolism in all CDK4/6 inhibitors. Risk may be because of platelet-mediated rather than coagulation-based. Multifaceted approaches strengthens our signal, but there is need for prospective risk model and preventive strategies because these all are retrospective. Thank you.
Thank you, Ashish. I'll request you to join on the panel. We'll take up the questions after the second presentation. May I now invite Dr. Rajiv Bhattacharya, Senior Oncologist from Peerless Hospital. He'll be talking to us on anti-HER2 treatment and cardiotoxicities, a few papers there.
Where is it? Can you just change? Yeah, thank you so much. Thank you, Vivek sir, for inviting me to this wonderful conference. Right now, I am giving a talk on behalf of Zydus, and the slides have been provided to me by them. And it concerns the anti-HER2 therapy. I think anti-HER2 therapy has revolutionized treatment in breast cancer, HER2-positive breast cancer, and their newer drugs are coming up every day. And what we tend to forget in the hula hula of the brilliant efficacy that these drugs produce is the toxicities this brings along. And cardiotoxicity is a very important toxicity in these group of patients, especially breast cancer patients who are also exposed to anthracyclines, which are other important cardiotoxic drugs. So this is the outline of my talk. I think I will talk about the background and a little bit of classifications, various drugs, their application, regulation of cardiotoxicity, and classification of the anti-HER2 targeted drugs. So we know that breast cancer is one of the most common cancers, and it is probably the most common cancer in females. Approximately about 20 to 25% of the breast cancer patients, they are HER2 positive. And there are multiple targeted agents. There are monoclonal antibodies, there are tyrosine kinase inhibitors, and the talk of the town antibody drug conjugates are also here. And we have to take into considerations cardiotoxic effects of all of them. So this is basically the classification of the anti-HER2 therapy. There are monoclonal antibodies, which are the trastuzumab and pertuzumab. There are TKIs, like tucatinib, lapatinib we used to use a lot and now use now as well, neratinib, and the antibody drug conjugate like trastuzumab emtansine and then trastuzumab deruxtecan. So these are the three categories. Now, monoclonal antibodies, the trastuzumab, it was approved in 1998. I think we all know how it improved the survival in HER2 positive patients. We use it in neoadjuvant, adjuvant as well as metastatic setting. And the cardiotoxicity is indeed a big concern with trastuzumab. So it inhibits the HER1, HER3 and HER4 receptors which are present in the cardiomyocytes, and that binding disrupts receptor interactions, oxidative stress and cardiac dysfunction and apoptosis. And this is there are two types of cardiotoxicity which are associated with the two drugs that are used in breast cancer. One is the anthracycline, which produce type 1 cardiocyte killings, which is oxidative stress induced. But trastuzumab, what it does is that it actually, there is a cardiomyocyte dysfunction it causes, and so that type of toxicity is reversible. And if you stop the drug, then the cardiotoxicity also reverses. That is not the case with anthracycline. So when you combine anthracycline and trastuzumab, obviously it becomes even more toxic. There is cumulative toxicity of these two drugs, and that's why we need to separate them out. That's why we space out. We do not give trastuzumab with anthracycline, and that's the famous AC followed by TH protocol that came into being. So these are the various effects. There are asymptomatic ejection fraction decline in 3.2 to 2.6% of the patients. Symptomatic heart failure was seen in about 2% of the patients. There was a meta-analysis which showed that severe cardiotoxicity with trastuzumab was at the tune of 3%, and mild to symptomatic cardiotoxicity was 1 to 80%. That wide variation is because of the various type of cutoffs and the criteria that were used in the trial. The higher risk was seen in metastatic breast cancer patients versus early breast cancer patients, and the randomized control trials also report lower incidence than observational studies. So real world risk likely was underestimated. Now the second targeted agent was pertuzumab. It was approved in 2012 and it blocks HER2 dimerization with the EGFR family. It is used along with trastuzumab. That leads to higher therapeutic efficacy, and there is no significant increase in cardiovascular toxicity versus trastuzumab alone, and common side effects are mostly rash. Diarrhea is a big headache. That's my experience. And in terms of the clinical data, the heart failure incidence is about 0.8% in the combo versus 1.49% in the trastuzumab alone arm, and ejection fraction decline was about 3% in both groups, and this has been confirmed by multiple trials and meta-analysis. So what in a meta-analysis it was shown that pertuzumab does increase the risk of clinical heart failure, relative risk of 1.97, but there was no LV dysfunction. So these are the drugs. The trastuzumab, it has clear cardiotoxicity. Pertuzumab, there is potential of cardiotoxicity. There are some symptomatic CHF and decrease in LVF also seen. These are the other, when you combine the chemotherapy along with trastuzumab or you various regimens, then you see that there is an incremental increase in the cardiac toxicities than when you use alone. Now let's move on to the tyrosine kinase inhibitors. These are small molecules that block HER2 signaling by inhibiting phosphorylation. They can cross blood-brain barrier and effective in metastatic breast cancer, especially in brain mets. We know HER2 positive breast cancer have a increased predilection for brain mets. The major TKIs that we have are lapatinib. Now we have tucatinib, neratinib. We have Chinese pyrotinib as well. Not available here. Cardiotoxicity was mostly reported with lapatinib, minimally with neratinib, but tucatinib did not show any cardiotoxicity. Lapatinib was approved in 2007. The mechanism is reversible inhibition of EGFR and HER2 blockers. Most side effects include rash, diarrhea, hand-foot syndromes, but cardiotoxicity was seen less frequently. The possible mechanism of cardiotoxicity is probably HER2 inhibition in cardiomyocytes, and in earlier studies, cardiac risks were at the tune of less than 2%. Meta-analysis showed that overall cardiac effect incidence was 2.7% in all cancers and 3% in breast cancer. And symptomatic heart failure were very few, about 0.2%. Most events occur within 9 weeks and some after 25 weeks. The next one is tucatinib. It was approved recently in 2017. It is a high selective HER2 inhibitor and minimal EGFR inhibition. That's why the cardiotoxicity has not been reported with this drug. Side effects mostly diarrhea, hand-foot syndrome, and nausea. Pyrotinib was approved in China 2018. The same mechanism, no cardiotoxicity was reported. Neratinib again 2017 for early stage HER2 positive breast cancer. It's an irreversible inhibitor, covalently binds to kinase domain. Side effects, again diarrhea, nausea, a little bit of cardiac events were seen in NALA trial. About cardiac events, arrhythmia was seen about 3.3% and ejection fraction decline was 4.3%, similar to or lower than lapatinib. So conclusion, no new cardiac safety concerns, and so neratinib is probably almost like lapatinib, slightly better in terms of cardiotoxicity. So these are the drugs that I just said. Only lapatinib has a little bit of it has cardiotoxicity. Neratinib a little bit, but tucatinib, pyrotinib is relatively cardiosafe. Let's move on to antibody drug conjugates. So we have the advantage is higher selectivity, lower systemic toxicity versus traditional chemotherapy. TDM1 and TDXD are the major ones. TDM1 was approved in 2013. It binds to HER2 receptor. The chemotherapy moiety DM1 gets internalized, and there is lysosomal degradation, DM1 release, and cell cycle arrest and apoptosis. Clinical evidence, there are multiple clinical evidence. Most common side effects are thrombocytopenia, elevated transaminase, fatigue, and cardiotoxicity were seen. Likely it is because of the HER2 inhibition of cardiomyocytes. And in phase 3 studies, ejection fraction decline was 1.7% of the patients was shown LVF decline. In a 2020 meta-analysis, cardiac events incidence was 3.37 and an LVF decline of 2.04%. There is limited long-term data, so more research is needed. Talk of the town, trastuzumab deruxtecan. It was approved in 2019, and it has shown brilliant results across all the stages. Now I think we have data on adjuvant, neoadjuvant, as well as we had a brilliant data in heavily pretreated patients in metastatic setting. Most common adverse events is nausea, fatigue, alopecia. These are the common ones that we face every day. Neutropenia we have experienced. Pneumonitis is a dreaded complication. There were deaths in the trial due to ILD. But cardiotoxicity is not clearly established. I think that although it has an anti-HER2 agent, it may have some cardiotoxicity, but it has not been studied to a large extent. So these are the two drugs. TDM1 has clear cardiotoxicity, but TDXD has not yet shown any cardiotoxicity. The multiple hit hypothesis, this is, the challenge is to link the microscopic mechanisms to clinical cardiotoxicity, which is selective. It affects some patients and is reversible. And type 2 versus type 1, I already elucidated that the type 2 is reversible, that is caused by the targeted agents. And type 1 is anthracycline. It is because of the oxidative stress induced cardiomyocyte damage, which causes irreversible damage. So, drug classification I have already mentioned. So trastuzumab has a well-defined cardiac event criteria that ejection fraction has to be come down 10% from the previous level, and often asymptomatic. We can use the GLS echo to detect cardiotoxicity in trastuzumab or anthracycline-induced cardiac events. This is the application time and reversibility, longer anti-HER2 therapy, higher cardiac risk. There is no consensus on cumulative risk unlike anthracyclines, and there were various trials on 6-monthly regimen like Pivot et al., Earl et al., and they showed that shorter cycle would decrease the cardiac risk but also decrease the efficacy. And it is reversible. So this is the regulation of cardiotoxicity for targeted drugs. Cardiotoxicity, we have to look after three things. That is, one is cardiotoxicity clinical biomarkers like troponin T, troponin I, pro-BNPs, etc. Permissive cardiotoxicity to get the maximum benefit, and the current status of cardiotoxicity. regulations. So I think cardiotoxicity clinical biomarkers will include ejection fractions. We will include global longitudinal strain. We are using it more and more nowadays, troponin and BNPs. And emerging biomarkers are SNPs, microRNAs, etc. And permissive cardiotoxicity is it's when to intervene. So we need to intervene at a time when we will not have much side effects, but we will not give up on the effect that the drug produces. That is very important. And this is the status of targeted drug cardiotoxicity regimen. So you have for trastuzumab, you need to look at the ejection fraction decline, CHF symptoms, etc., etc. And there are other for lapatinib and TDM1 as well. So this is the preliminary regulatory process. We have to check out for all the past comorbidities, and then we have to assess how to give the drug. And that is the conclusion. I think HER2 therapy improves survival but raised cardiotoxicity concerns, and current regulation focus on monitoring and managing risk. But there are some gaps, and various guidelines of FDA, Europe and China. They recommend baseline risk assessment and regular ejection fraction biomarker checks. And we need more long-term studies to learn about this. Thank you.
Thank you, Dr. Rajiv. So both the speakers, I'd like to join on the panel, and it's open for a Q&A session. Let me ask Dr. Rajiv, what do you do when your EFE starts dropping or GLS dropping? Do you give protective therapies or for the concept of permissive cardiotoxicity?
Sir, if the ejection fraction goes down below 40%,
say by 5% and asymptomatic.
Yeah, in that case, if the patient is asymptomatic, it has gone down by 5% and the ejection fraction is above 45 to 50%. In that case, we will continue the therapy and give protective drugs.
So what all protective therapy in your practice you do or leave it to the cardiologist?
Sir, here we just put the patient on regular follow-ups, and we give statins and beta blockers. These are the agents. Along with, we have a discussion with our cardiologist team, and we give the protective medications. And we check the patient that more frequently with ejection fraction. And we also use GLS echo in those settings.
Yeah. Any question from the floor? Use the microphone, please.
It's actually, there's no real cardioprotective drug which can be used to prevent this kind of toxicities. Another thing he pointed out that if you have a cardiac injury secondary to adriamycin, the injury is not reversible, but heart failure is always reversible. You can treat, and you can give anthracycline again. And if it is, as he said, trastuzumab is 96% reversible in 6 months' time. But if the point is that there is no drug you can actually give before, and GLS per se in this group of patients has not made any clinical difference in the management. So it cannot be used. If you want to use GLS, you have to use it in immunomyocarditis or in amyloidosis.
Yeah, regarding publication, we have got data like on statin, STOP-C trial, we have a SARA trial with ARNI. So there are a lot of data coming up in the field, but they are very small in number.
Even in the SOCO trial,
yeah.
Even though initially it showed benefit and we were all upscale about it, but the 3-year data at the end of it has shown no benefit.
Yeah. Because beta blocker and RAS blocker is the way to go for asymptomatic LV dysfunction. You forget about whether it's cancer related or any other. Other drugs are coming up, probably ARNI will catch up more than the ACE inhibitor and ARB. Thank you. Yeah.
I think we have a very interesting session on in the evening coming on from discussing these trials itself. So probably we'll continue this debate, and let us move the session forward. Let us start the next session, and maybe we can continue.
So we thank both the speaker for doing a wonderful job. Thank you, Ashish. Thank you, Rajiv.
Thank you, sir. Sir, can I request our esteemed chairperson to please chair the next session as well? I'll also invite our sir's co-chairperson, Dr. Munna Das, consultant interventional cardiology and electrophysiology at Narayana Specialty Hospital, Howrah.
Good morning, August audience. So our speaker is Dr. Srijata Raichaudhuri. I think the first topic will be meta-analysis for permissive cardiotoxicity in HER2 therapy from an article in BMC 2025.
Good morning, everyone, and I'd like to thank Vivek sir and the organizers for inviting me to speak today. So as the chairperson mentioned, my topic is a meta-analysis discussing permissive cardiotoxicity in HER2 therapy for breast cancer patients. This is the article we'll be discussing today, published this very year in Cardiovascular Toxicology Journal. So just a brief background, as we all know, about 15% of breast cancers have HER2 overexpression. And we know that cardiotoxicity is a well-known side effect of anti-HER2 therapy. We also know that LVEF less than 50% for most oncologists is considered a relative contraindication to the use of trastuzumab. In patients who are receiving concurrent or at the same time are going to receive anthracyclines or have previously received anthracyclines, this risk is even higher. The cardiotoxicity, as my colleague mentioned, is reversible. There is no permanent damage in most cases, and given a few months of treatment interruption, we do see recovery in heart function. The incidence of asymptomatic heart failure is about 0.8 to 3% when chemotherapy and trastuzumab are given concurrently, as compared to only around 0.45% with chemotherapy alone. And just a simple asymptomatic decline in LVEF is about 2 to 7%. Some studies have reported higher, around 27%. Now, what is the concept of permissive cardiotoxicity? It is in these asymptomatic patients or relatively mildly symptomatic patients, can we continue trastuzumab to complete the designated course of treatment with an acceptable risk of mild cardiotoxicity in these patients, given the survival benefits we have seen in this patient population with HER2 therapy. So this is a brief graphical abstract, and given the short time that I have, I'll just go over this to explain how this meta-analysis was conducted. The authors looked at multiple studies in the PubMed, Cochrane, and Embase databases up till October 2023. Initially, they screened about 1,900 studies, and after a quality assessment process and excluding irrelevant studies, ultimately 8 observational studies were included, including 6 retrospective and 2 prospective studies. A total of 630 patients were initially included in the analysis, and ultimately 222 patients were chosen for the final analysis because these patients continued trastuzumab even after an asymptomatic decline in their LVEF. Study was performed using standard PRISMA guidelines. I'll come back to this in a little bit. So this is basically a list of all the studies that were conducted. Some of them were retrospective, some prospective. The median age of these patients was between 52 to 57 years, as mentioned in this table. The median follow-up was anywhere between 2.5 to 52.5 months, so a very broad follow-up time. Some of these patients had a baseline low LVEF around 40 to 44%, as you can see. This was in about 3 studies. In 4 studies, they initially had a normal baseline LVEF, but went on to develop a decline in LVEF as treatment progressed. And one study allowed patients with both a low baseline LVEF as well as a progressive decline in LVEF during the course of treatment. Both metastatic and early stage breast cancer patients were included in the meta-analysis. This is a summary of the cardiac outcomes. The only thing I'll point out here is in a couple of these studies, like the one by Leong et al., given cardioprotective medications, the baseline LVEF increased from 40% to 51%. As per the meta-analysis. And another study here by Zhu et al. Shows that the LVEF with cardioprotective medications improved from 48 to around 57% at follow-up. I'll come to the major findings in this particular slide. So the authors found that the pooled prevalence of cardiac events given trastuzumab therapy was around 18%. The mean time to subsequent cardiac events was from 10.5 to 60.8 weeks. There was a very lower cardiac event rate with the use of cardioprotective medications such as beta blockers, ACE inhibitors, and angiotensin receptor blockers. The rate was around 8.7 to 13% as compared to 18%. The pooled incidence of cardiac mortality was 5%, which is relatively low. And the pooled incidence of all-cause mortality after a sensitivity analysis was found to be around 6%, also relatively low. So coming back to this graphical analysis, given this relatively low incidence of cardiac events and mortality, the authors concluded that continuation of planned trastuzumab therapy with the concomitant use of these cardioprotective medications can be a safe and acceptable approach in a certain subgroup of patients. Now the question is, which subgroup of patients is this? And I found this particular guideline from the European Cardio-Oncology Society quite helpful in this situation. They are saying that in asymptomatic patients, mild to moderately asymptomatic, meaning the LVF is above 40%, there should be an MDT or multidisciplinary team discussion and then consideration of continuing HER2 therapy while at the same time giving cardioprotective medications to these patients. Now in the symptomatic group, so those with a severe asymptomatic patient with LVF less than 40% or clear-cut symptoms of heart failure, there it is a bit more controversial as to what should be done. You could consider continuing anti-HER2 therapy along with the use of cardioprotective medications and treatment of heart failure with diuretics, etc. But in most cases, we find that a temporary treatment interruption of trastuzumab with resumption at the time of improvement in the LVF is what we see more commonly being done in clinical practice. So the take-home message that I find is that continuing trastuzumab with the use of concomitant cardioprotective medications can be a safe and effective strategy in a certain subgroup of patients, particularly those with mild to moderate asymptomatic cardiac dysfunction. Thank you.
Ma'am, thank you for a nice depiction of the meta-analysis. But coming to the real-world scenario, we can we justify ourselves starting anti-HER2 treatment with trastuzumab in a patient who has LV dysfunction and patient, what you told, are asymptomatic patients. So asymptomatic patients in LV dysfunction, in your practice, what is the real cutoff that you will take these patients for trastuzumab in consultation with your cardiologist?
Thank you for that question. So yeah, in real life, I think most of us feel comfortable when the LVF is above 50%, some of us around 45 to 50%. Anything below 40%, despite all the guidelines, we don't feel that comfortable because we don't know what kind of side effects they're going to have.
Yeah. So ma'am, I think it's a balance between life-saving chemotherapy or other anti-cancer treatments vis-a-vis our deterioration of LV function, patients going to avert heart failure and rehospitalization and all these issues. So I think one is basically a pre-treatment with the standard 4-pillar anti-heart failure therapy. What the meta-analysis showed was the use of ACE inhibitors or ARBs. Now as a current protocol, all of us, unless contraindicated, we use ARNI. So ARNI is actually a combination of two medicines. It is an ARB plus a neprilysin inhibitor, which is much more effective. We have seen in our real-world practice in most of the patients of heart failure, except those who have a large scar burden. Second, and also it can, your benefit can extend to EF up to 55 to 60%. Means even in patients who have a EF around 55%, jolly well they can qualify for ARNI. So that is the trial data that they have shown. Second is the use of MRA. Because what I found in the protective therapies, MRA was not mentioned. Means spironolactone or its analogs were not there. So current heart failure therapy and the early diagnosis of LV dysfunction means we don't have to wait for a 50% drop to diagnose an LV dysfunction. We can diagnose LV dysfunction quite early with our newer imaging modalities like strain imaging that we currently use in echo to find out a GLS. So I found a GLS greater than 15%. Actually, it should be projected as normally a GLS of minus 18% and above is taken as normal. And a drop to minus 15% is taken as abnormal. So that is the cutoff. So minus sign indicates the lengthening thing that we measure. So a shortening is a positive thing. So main issue is that dedicated software available in your echo lab with the same experienced operator doing the same patient over a serial follow-up can pick up early LV dysfunction, and then you can actually tailor your therapy dose, minimum dose that is not non-toxic or least toxic to your patients.
Thank you, Dr. Srijita. May I now invite Dr. Nihanti Srinath? Is he there? Yeah. The topic is a de-escalating cardiac surveillance, whether you do a 3-monthly echo or a 6-monthly in a low-risk patients. Over to Dr. Srinath.
Good morning, everyone. Prior, I would thank Dr. Vivek Agarwal sir for giving me an opportunity. Not wasting much time, I'll be focusing mainly on the low-risk cardiac surveillance, especially in management of breast cancer. So currently, why is it so important for us? We started with an era, initially there was a treatment of oncology, then came up the toxicity, and currently we're dealing with survivorship and quality of life. So keeping this with the background, what are the evolving landscapes are? Currently, whatever therapy we are using, that is, let it be trastuzumab, anthracyclines, or even the radiation to the chest wall, has a bit of toxicity to the cardia. So the therapy-induced cardiovascular injury syndromes of late have increased in number. And then there is an epidemiological burden. According to the data of the 2025, we have seen that almost 9 to 18% of patients exposed to anthracyclines and 5 to 8% of HER2 patients develop some form of cardiac toxicities. So the mechanism can be either ways. One is a mitochondrial oxidative apoptosis or either a PIK3-AKT inhibitor pathway. So currently we have various guidelines, let it be the ASCO or the ESC 2024 guidelines, which says that how can we monitor especially the EF based on the risk stratification, which I'll be explaining. So currently the definition of low risk, this is basically according to the ASCO 2025 framework. So we do have a low risk and a high risk. My main focus would be on the low risk. So looking into the cardiovascular history, if the patient has any absence of pre-existing heart disease, coronary artery disease, arrhythmias, EF more than 55%, global longitudinal strain of greater or equal to 18%, and these patients are also exposed to any non-anthracycline based or a short HER2 based therapy, and moreover, age is an important factor, which is less than 60 years, in absence of hypertension and all other coexisting comorbidities. So this is the current risk stratification of low risk patients in our setting. So who are the patients who require the surveillance? So do all the patients require surveillance? Yes, we use umpteen number of anthracyclines in HER2 therapy. So who are the patients especially for the surveillance are? One, whom we are exposing to anthracyclines. Currently we have various other, even in a metastatic setting, we have TKIs, immunotherapies in TNBCs. And moreover, high-risk consent are the patients where anthracycline exposure is more than 250 mg per meter square with dual HER2 blockade been added. So currently focusing on the low-risk cohort where either an isolated trastuzumab or a non-anthracycline based regimen patients are used, we currently look into various de-escalating biomarkers, mainly the baseline echo. So this is just a brief, I won't get into the mechanism of the pathophysiology. Anthracyclines, as we all know, it's an irreversible cardiotoxicity. HER2 has a reversible type 2 LV impairment because of the PIK3-AKT pathway blockade. Immune checkpoints, VEGFs, and radiotherapy, it's morely myocarditis, myovascular part, and also based on the remodeling. So we can see more of late onset of the restrictive pattern. So what are the current epidemiological chemotherapy-related cardiac dysfunction? So we do have a various trial base and registries. So it is the Cardiotox European Registry, the JAMA Oncology, and the HERSAFE Steady Oncology group, where we currently look into the cumulative anthracycline dose. So for any patient, more than exposure of 300 mg per meter square, age of greater than 60 years, and any global dyskinesia of less or equal to 18%, with other coexisting comorbidities like hypertension, baseline EF of less than 15, or exposure to any dual HER2 blockade. So we have the various phenotypic inset of type 1 or type 2 damage which occurs. So currently if you look into various algorithm, how do we monitor is, one is the baseline echo. We get prior to the start of therapy, if the patient is exposed to anthracycline and trastuzumab 3 monthly, we always look into the drop in EF. If there is any drop of less than 10%, so if the patient is exposed to anthracycline, then the patient has to completely avoid anthracycline. If it's a trastuzumab, maybe again an attempt can be done if there is increase in the EF. And ECG also, electrophysiological remodeling is also taken care. Now there is a role of cardiac MRI. So basically to look for the structural abnormalities also. If on an echo if becomes inconclusive, then we advise the cardiac MRI. So the toxicity, any drop of EF less than 10% as a subclinical decline. Grade 2 is more than 10% from the baseline with any global hypokinesia also. Grade 3, patient becomes symptomatic, EF is less than 40. And grade 4 is either patient ends up in a cardiogenic shock requiring further ICU support. So we do have various pharmacological prevention which I won't be getting in detail, but the drugs which are commonly used are the AC inhibitors, beta blockers, dexamethasone and statins. So based on the drop of EF, definitely for anthracyclines, the drug is going to be contraindicated, but for radiation and trastuzumab, again, give a break of maybe a 4 weeks to 6 weeks period, look into the EF drop or EF increase, and based on that, it can be added. So these are the current management of established toxicity of LV dysfunction based on either we start with the medical management, if required, any intervention needs to be done in prior. So coming to the what are the precision, as an oncologist, currently we are focusing on the precision oncology. So we do have various biomarkers. Pro-BNP is one of the factors in that. So looking into the various therapeutic innovations and study, one is the AI cardio base. So there is, as we are quite aware of the artificial intelligence popping up in every field, so we do have machine learning driven therapy based on the titration and the surveillance optimization. And there is another series called the Cardio-Ridnux, which focuses mainly on the imaging frequency and de-escalation. So it can either be done a biannual or an annual based echo is recommended in this series. And where we do have the cardiotoxicity, as CAR-T is currently involved in both hematological and solid malignancy. So we do have various immunophenotypic mapping of the CAR-T associated myocarditis and arrhythmias. So how I would like to conclude is it's mainly a multidisciplinary integration. It's just not the oncologist, it's both the cardio-oncologist taking in account. We have a lot of patients who come in with low risk of drop in EF. Definitely you can't avoid anthracyclines in those patients because anthracyclines have been the backbone of the breast cancer. But if the risk of the patient is less, definitely in certain situations you can avoid them. And others are imaging specialty and data sciences. So just a brief word, I won't take much time, sir. Just a brief word on the effectiveness in the health economics. Definitely all these interventions are expensive. So the easiest way to monitor a patient is by a 2D echo. So we do have various ongoing trials also. So the current outcome or the take home of this talk would be that there's a shift in paradigm. Initially we used to wait for complications to occur. Now is the era where we are trying to look, does our drug cause any toxicity to the patient? So the better predictive markers, a proper analysis and a preventive examination is the take home of everything. So we need to integrate the AI analytics, the multi-omics, biomarker driven therapy, looking into the cardiac MRI which even assists the digital strain, and various guidelines have currently evolved, especially the ASCO 2025 which most of the oncologists follow, which says that the dynamic and the data driven risk model is important. If the patient even falls in low risk, it's better to do serial monitoring. If anthracyclines can be avoided, if it's a low risk patient, then definitely avoid it. But in unavoidable sequencing, definitely a follow-up is mandatory. So the vision is cardiotoxic free survivorship would be the take home message. With this, I would like to conclude my talk. Thank you.
Thank you. How do you manage this rise and drop in NT-proBNPs during therapy? Is there any cutoff, 10%?
No, so currently ASCO has said, sir, increase in 10, they do say that it's better to avoid the medication, but there are a lot of trials and...
No,
that is for the
not for EF.
NT-proBNP, not
Okay.
The biomarkers.
So the biomarkers part I'm not quite aware of, sir.
Because as a cardiologist, we see a lot of noises with the biomarkers. And there is no India-specific study based on BMIs, elderlies are very low. So there are a lot of things. And regarding echo EF, it man-to-man variation. So inter-observer variation is so high. So I think the future is AI. Probably a few studies is there based on ECG. Your ECG can pick up whether you are going to develop heart failure or not. So.
Because some of the studies, especially the ASCO, and there is a Rednux study which actually code about the pro-BNP levels, sir, but it's still under clinic. It's not implemented in a phase 3 data yet. So we don't have a clear...
What I think, NT-proBNP baseline can give us an index of the risk of the patient who can go to further deterioration of LV function or overt heart failure rather than as a serial marker. So this is my take, what I have seen over years working with Dr. Vivek Agarwal. And another thing is what is the frequency of echo follow-up we will advise in a patient, because in your real world practice, what you will, because you have to make it also cost effective, what is the frequency of follow-up on a patient who has this HER2 therapy or anthracycline based therapy?
So minimum at least a 3-monthly follow-up is indicated in our...
Baseline, once you give,
Yes,
say
baseline.
you have given 250 milligram per meter square of the body surface area, anthracycline dose. Now, baseline you have done an echo. Now, what should your advice be to the echocardiographer technician or maybe your discussion with the cardiologist at the next echo follow-up?
So if patient comes, we take a clinical history for every cycle of chemotherapy. If patient is
No,
asymptomatic...
at what point will you bring the patient to your clinic?
No,
Means
sir,
after
every
giving the
cycle
therapy?
she has
Every
to
cycle?
Every cycle. For example, if I'm practicing a dose-dense anthracycline regimen, 14 days the patient visits to me in my clinic.
Okay.
So then I would ask, basically first I would take a clinical history. Does the patient have any breathlessness? If patient is asymptomatic, I would get at a span of 3-monthly interval. But if patient is symptomatic, complain of any shortness of breath based on the WHO reading and all, then I would immediately advise an echo
Okay.
for her.
Yeah,
So
but
otherwise
in
a
our
3-monthly.
practice, we at 2 weeks, because there's a phase of acute cardiotoxicity with anthracyclines. So we, apart from the routine clinical evaluation, we will do an echo at 2 weeks. Once the 2 weeks thing is okay, patient's EF is normal or close to normal, then we will follow them up at 3 months interval.
that's
So
what I
the
was
initial
quoting.
2 weeks echo is a mandatory for in our institute.
Okay. That's what I was quoting about health economics, because I come from a trust hospital where even echo is chargeable to patient.
Yeah.
So from advising
So,
an investigation, I need
we thank both the
Yeah, I
speakers.
think we can take this up in the panel
So
discussion.
we close the session here, thanking my co-chair, Dr. Munnadas.
I welcome our moderator, Dr. Amishwara, medical oncologist and co-founder, and he's the director at Hope Oncology Clinic, New Delhi. Sir, would you like to introduce your panelists, sir?
Okay, thank you, Dr. Vivek. My panelists are Dr. Srijit Kamtakar. We have Dr. Srijit here. Dr. Sujit, I'm sorry. Dr. Rajiv Bhattacharji. Dr. Rajiv Bhattacharji. Dr. Partha Sarthi Roy. Dr. Nihanti Srinath. Dr. Munna Das. Dr. Bijay Prakash Pandey. Dr. Srijata Ray Chaudhary. Okay. So Dr. Sujit is from ACTREC, Navi Mumbai, Department of General Medicine. Dr. Rajiv is consultant medical oncology in Peerless Hospital, Kolkata. Dr. Partha Sarthi Roy is professor and head Department of Medical Oncology, B. Barua, Guwahati. Dr. Nihanti, you just heard. Dr. Munna Das is a consultant interventional cardiology and electrophysiology, Narayan Super Speciality Hospital. Dr. Bijay Prakash Pandey is senior consultant cardiologist again in Narayana, Howrah. And Dr. Srijata is assistant professor medical oncology, Chittaranjan National Cancer Institute, Kolkata. Okay. Okay. So we have covered the panelists. So the 3 papers which we are trying to cover in 27.3 minutes. Recent pharmacological data on cardiac toxicities of CDK4/6 inhibitors. There is a meta-analysis on cardiac toxicity of HER2 therapy and permissible when would you stop or continue giving anti-HER2, and de-escalating cardiac surveillance in low risk, which Dr. Nihanti tried to touch in the last paper. Okay, so I will start with a very interesting case and how the genesis of this panel also happened in my practice. So 78-year-old female, mother of a cardiologist and my MBBS batchmate. HFpEF is already diagnosed with recurrent UTI sepsis. Every third, fourth month, she had urosepsis, was admitted for last 2 years. Arthritis was relatively well controlled. She was diagnosed with stage 4 soft tissue sarcoma. I would not go into the details of that because that is not the discussion here. Based on NGS, we started on palbociclib. As far as the disease is concerned, patient is fine for last 2 years without any progression. So I was very happy that palbociclib was working. During 1.5 years, she had 3 episodes of cardiac failure and pulmonary edema, so more of a right-sided failure, but according to my cardiologist friend, it was right and left both. So he asked me, okay, Amish, I know that my mother already has HFpEF, but can palbociclib be the culprit? And let me first ask our cardiology friend, Dr. Munna Das. Sir, you are aware of CDK4/6 inhibitors which we commonly used, especially in breast cancer?
Not much, but coming to this question, before picking up palbociclib as the culprit agent, I will go into the other causes which precipitate heart failure with preserved ejection fraction.
We are talking of this particular patient and we have 3 papers to cover. So I would, so if you are not aware of palbociclib causing, right, sir? So Dr. Pandey, sir?
Yeah, I am also not aware about this molecule.
Okay. So Dr. Sujit, you are an ACTRAC TMC. You can't say yes, you don't know.
Sir, this drug is being quite used oftenly, but we did encounter much of the cardiac complications after the use of these drugs, sir.
Absolutely, you are absolutely right. You know, Dr. Srijata, you have any experience palbociclib?
I have experience with palbociclib, sir, but not with this kind of cardiac.
Not with this kind of, okay. Dr. Partha?
Yes, we have encountered arrhythmia, but not failure.
Not failure.
Not failure.
Okay. Dr. Nihanti?
Yes, sir. I also agree, sir. Even I have not encountered any failure, especially with palbociclib, sir.
With palbo. Dr. Shirish, sir, Vivek, any experience of palbociclib causing? No, nothing. Okay. So I was not the only one. That is what I told him very categorically. I said, your mother's heart failure is not because of palbociclib. This I kept telling him again and again. He said, okay, then, you know, she has HFpEF and she has other comorbidities. But then he sent me this paper, which was published in November 2024. And I was surprised. I said, okay. And I read about this paper. And then I got an email from Cardio-Oncology about the similar pharmacovigilance paper. And I was really surprised that there were so many such papers based on FDA's adverse event reporting system from 2016 till 2024. 2016 because that was the time when palbociclib was introduced and was approved. So this is the paper on which I have taken it, and to my surprise, basically, if you see palbociclib, myocardial infarction was 14.9%. Now this was a revelation to me, something which is we have not seen. Dr. Roy, in your practice, have you seen this type of
myocardial infarction you're asking?
15% myocardial infarction.
No, I have not seen.
In fact, we normally tell patients that when they have a cardiac abnormality, we say, आपके लिए palbociclib safe है, isn't it? And that is what we do that. Dr. Rajeev? He's not here. Okay, right. So, Dr. Nihanti, 15% of myocardial infarction.
So I have not seen even a single case in my practice.
I have not seen. So if my cardiology friend's mother has cardiac failure because of palbociclib, for me it would be the first case which I had seen. Otherwise, palbociclib is relatively safe. So, you know, this is, so Dr. Roy, based on this particular, this is a FDA, adverse event reporting system of 9 years, and 9,000 plus patients received palbociclib. What do you take of this paper? Is it going to change the way you look at CDK4/6 inhibitor?
See, as far as the three CDK4/6 inhibitors are concerned, as you are right, in elderly patient, if you want to say the cardiac safety profile, probably palbociclib must be the most safest drug. Whereas on the contrary, abemaciclib is associated with more and more incidence of VTE. But seeing this paper with more than 7,000 popular patient having this much of toxicity, definitely I will be very much skeptical in advising palbociclib from tomorrow onwards.
Pandey sir, this paper is in front of you.
Yeah, I really wanted to ask you because you have gone through this. How it was adjudicated, myocardial infarction, what was the criteria in this paper?
So sir,
it was enzymatic rise, ECG changes.
How the FDA adverse event reporting system happens is that it is an acute event, what you are supposed to report. So you miss out on chronicity, you miss out on comorbidities. If it is written, it is written. If it is not written, because that is few drawbacks of this particular paper. So all the acute events which are reported on the system or on the website is what is taken. So if you ask me the details of the symptoms and all, right now we don't have in this paper, but if you see myocardial infarction, cardiac disorder, atrial fibrillation, palpitation, cardiac failure, they have written everything.
Because as a cardiologist, I can tell you myocardial infarction, unless they follow the guidelines, is most likely a vague one.
So US
rise in troponin I with non-obstructive coronaries are pretty rampant. And with the use of high sensitivity troponin, we daily get this troponin 200, 3000 get referral from intensive care, coronaries are normal. So I think we have to follow the
we have to take
paper
it.
in
You are saying
detail.
that we are taking with a little pinch
Unless
of
there is
salt,
a causal, so in the medicine you have to prove it is the causal mechanism or not. If not, you can't explain, you have to just brush
I
it
take
on.
your point, and I'm sure, sir, the paper, I couldn't see the definition of myocardial infarction because that is not probably which I wanted to look for that, but I will go through it and get back to you. Yes, sir.
So, Amish, there is some literature reported there is an interaction between the CDK, CD4 and PPIs.
Yes,
so
especially lansoprazole.
Yeah, it definitely reduces the efficacy.
Very common. Yeah.
It reduces the efficacy, but also increases the chances of MI.
So lansoprazole, they say QTC prolongation along with CDK4/6. What I read, sir, but I think
so I'm not using PPIs with TKIs.
Okay.
I'm mainly going for the H2 blockers. I don't know what others.
But I don't know about vonoprazole, which is once a day, new PPI. I think it takes care of QTC. The vonoprazole is a new PPI, once a day, not related to food. In fact, gastroenterologists have changed their practice to vonoprazole now. So this is something, but your point is right. And there's a very interesting another finding that median time to hypertension, if you see, which was just 30 days with ribociclib, which is there. Dr. Roy, how frequently you check? Every time the patient comes to you, obviously the vitals are taken. But do you tell the CDK4/6 inhibitor patients to take BP regularly at home?
At least once a week, not that regular.
Once a week.
At least once a week, recording.
In your busy practice, you have a time to look at those once a week?
I am not looking personally. I just wanted to ask the patient to record their BP weekly so that in the every visit they are coming to me, they are coming with the reports.
Right, okay. So we'll move to the second case in the same this thing. 42-year-old female, and this is very, very interesting. C-T3N2 disease, HR positive with 6 lymph nodes, grade 3. Treated as per standard guidelines, adjuvant abemaciclib based on monarchy was given. After 2 months, she complained of sudden palpitation. BP was 140/90. Her baseline BP was 130/80, 120/70, but never like 100/70 or 110/60 like that. ECG echo normal. Now GLS was minus 17%. Dr. Munna Das, your take on this particular slide.
Yeah, so the EF around 55%, as you mentioned, is normal with the GLS borderline, means it hasn't dropped to minus 15.
What is GLS, normal GLS in your practice, sir?
Normal GLS will be something more than minus 18%.
Minus 18%, okay. Right. So this particular patient, does this patient have, and based on this slide,
any halter or something done for this
halter
patient?
was done, sir, halter was negative.
And the baseline ECG not available?
Baseline ECG must be available, because before any CDK4/6 we give, I'm sure it must be normal, because otherwise I would have mentioned. This is a real case basically, a very, very interesting first in my career.
Okay.
So this Dr. Ray Chaudhary, based on this particular slide,
I mean, the GLS, I think.
minus 18 ले लो. Sir ने बोला minus 18 normal है, तो let's take minus 18.
So it's less than that. So there is some kind of asymptomatic decline in
some
the GLS.
kind of asymptomatic. So assuming GLS is minus 18, then
it would still be normal only, sir.
Then it would be normal. Okay. So my cardiologists, they say 17, 18 is normal, and that is what it was there. Pandey sir, you also mentioned about GLS when you were chairing the session.
So
is it the earliest sign of cardiac dysfunction?
Absolutely. And regarding the value, you have to be sure which vendor you are using in your hospital, because the GLS value varies from vendor to vendor.
Okay.
For someone it will be 15, for someone it will be 18, whether it is a GE, Philips. So you have to sure about the.
Dr. Nihanti, are you taking GLS deciding cardiotoxicity for your chemotherapy or trastuzumabs or CDKs of the world?
Sir, to be really frank, prior to this conference, seriously, I'm telling, actually I read about GLS recently. So I was only looking at the EF. Maybe then, if patient was more than 60 with comorbidities, then I would look into all the parameters. But yes, after reading this, I would consider now, sir.
Now
prior I was not.
Alurkar sir, are you using GLS in your practice for deciding the dose or interruption?
So any patients on IOs or TKIs or TEs or GLS at baseline, all patients identical.
Right.
Then every 3 months they need to work on.
So if the ejection fraction is 60%, but GLS from minus 18 has dropped to minus 15, will you interrupt your drug? Minus 18 to minus 15. So this was the review. Let me.
It's not an indication at all. The GLS based interruption of therapy alone is not indicated.
Yeah.
It is not clinically meaningful at all.
Right. Okay. So anyone in the panel agrees with sir?
Actually, there is a concept of giving a breathing period vis-a-vis complete interruption of therapy. So point is, like, if you have, so you have to have some check thresholds. Okay, so you cannot allow your patient unknowingly to go into overt heart failure. So if you have a drop in GLS to like anything below minus 15, then you should be cautioned. You should actually
we know the
upgrade.
dysfunction is coming.
So,
Dysfunction might come,
I think
but
the
it does not stop medication.
No,
Right.
we are not
Treatment of
asking you
cancer
to
is
stop
more
it,
important.
but you
Das,
should
sir,
be
Das,
cautioned.
sir,
Yeah.
I think what he's saying is right. In that review paper which I gave, they said that the GLS alone is just an indicator. Don't do anything, don't act only on GLS, but GLS with TROPI or GLS with anti-pro-BNP, the sensitivity and specificity touches 90%, sir. So if your GLS is low, I think then we should go for biomarker, and that's where we do. So this particular patient, what did we gave some antihypertensive, tried to control, because 140/90 was just starting of hypertension. Palpitation continued, and the highest reported heart rate was 140. ECG echo remained okay. Cardiologist said, Amish, palpitation and anxiety ho sakti hai, let's add beta blockers. 3 months later, we continued abemaciclib. 3 months later, GLS is minus 13%, anti-pro-BNP is 450. We did not do baseline because 42-year-old patient, we never suspected anything. Now, Dr. Ray Chaudhary, should we start doing biomarkers if we are doing GLS from tomorrow in every patient baseline?
So, I mean, looking at this paper, it appears so, but in practice, I don't.
Practice you don't. Okay. Pandey sir, what do you do now? See, 450 is anti-pro-BNP current. We do not know the baseline.
So for anti-pro-BNP, there is a set guideline from European, American. If whether you are in sinus rhythm or AF, and based on your BMI. This is probably AF, so cutoff for AF is 500 and above is bad.
So ECG was sinus rhythm.
No, he said heart rate 140 cannot
Heart rate
be
was
sinus.
140, yeah.
It,
No, sir, palpitation mein reported highest heart rate.
okay.
According to patient was 140.
So considering if it is sinus, this is
It is
abnormal.
sinus, sir.
So
So
cutoff
this
is
is
250, 500, 1000.
Okay.
So anything
Right.
above 250 in sinus rhythm
Right.
with BMI less than 35 is bad for me.
Okay, perfect. So this is what Dr. Niyanti, Dr. Pandey sir has given you this feedback. What will you do in this patient now?
Sir, so even I have the same query, sir. If patient is doing good on abemaciclib, currently she's symptomatic. In case she was asymptomatic, would we still want
Your
to?
gold standard was echo in your practice.
Yes, sir.
Echo has been normal all throughout.
But
Would
now
you
looking
stop
at this,
abemaciclib? I will move forward. We have 12 minutes left. Palpitation didn't stop in this particular patient, and anti-pro-BNP increased GLS from -13 to -12. We finally stopped abemaciclib, and everything settled, and patient became okay. So this was my first case of palpitation with abemaciclib, echo remaining normal, ECG remaining normal, but GLS and biomarker helped us saying that there is a cardiac event happening with abemaciclib, and which was there. So we'll go to the second paper, cardiotoxicity with HER2 directed as a meta-analysis. Dr. Niyanti and then Dr. Partha Roy. Dr. Niyanti, we use so many drugs. I have still not used niratinib, margetuximab, कोई एक patient अभी लेके आया है, but I have not used. So out of these, which one is the most cardiotoxic according to you? Name just one drug.
it's a combination I would consider, sir.
Combination you would. Combination of Tras2 with PER2, Tras2 with Lapatinib,
So even Tras2 with Lapatinib combination.
Tucatinib, Tras2 and Capecitabine, will that be the most
Sir, now even
cardiotoxic?
Tucatinib has cardiotoxicity.
Okay,
So
okay, right. So, Dr. Roy?
I think combination of Trastuzumab plus Pertuzumab is not added any cardiotoxicity over and above Trastuzumab.
Okay. What is the most cardiotoxic according to you?
Trastuzumab.
Trastuzumab. Dr. Vivek? Trastuzumab alone. Siri sir, you agree with that? Okay, perfect. I think this is what I agree with everyone what they have said. Still, trastuzumab remains number one cardiotoxic as far as incidence is concerned. Addition of pertuzumab has not shown to be much this thing. TDM1 is the least cardiotoxic amongst all, and TDXD, the recent meta-analysis show 0.2 to 1%, so probably it is further less cardiotoxic compared to that. So with that we will come to one more case. So it's a 57-year-old female, breast cancer, CT3N1, HR negative, HER2 positive, IHC3 plus FISH positive, let's put that. Neoadjuvant Phesgo, I am using the word Phesgo because subcutaneous, there is no other brand available, but plus chemotherapy, followed by surgery, followed by RT, and followed by maintenance Phesgo. Every 3 monthly echo is what I have been doing till now in my practice. After 8th maintenance, showed LVEF of 50%, baseline 56%, anti-pro-BNP and TROPI negative. Cardiologist said, this is just one observation. Dr. Vora, you can decide to continue. If you see 56 to 50, it is more than 10% drop in LVEF. Dr. Niyanti, will you stop trastuzumab at this point?
no, sir, I wouldn't stop trastuzumab.
You wouldn't
No,
stop
sir.
trastuzumab. Okay. At what point of time would you asymptomatic and say LVEF is 45%?
So if there is a drop in baseline more than 10%, or even if any
This
of
is 10.6%.
so then, so I would still wait, sir. I wouldn't.
You wouldn't stop.
I would look
If,
into other
if
markers.
LVEF is 48%,
So I would stop.
then you would stop. So magic figure of 50 is required.
No, sir, but at least now currently, because these predictive biomarkers are available, especially when there's a dilemma, I would get the pro-BNP
Dr.
levels.
Sujit, what is the, in ACTRAC, what is the policy?
So we actually do the same thing. We wait till the EF is 50%, or the 10% fall is there.
So this is more than 10%.
More than
fall.
10. But in this case, we would like to continue the trastuzumab as considering the long-term survival benefit with the trastuzumab for the patient.
पांडे सर कुछ और हमको हेल्प करो. I am asking you कि सर very precious this thing. Patient is cured of cancer right now. All we are doing is maintenance. Please, sir, help me decide whether heart is normal or not.
As I said, there is a variability in the assessment of EF. If you want
Sir,
to be
you have done the 2D echo and it is more than 10% drop.
if you want to be purist, just do a MR. That will give the accurate picture of EF.
Dr. Mudna Das, how frequently you do MR or you suggest MR in cardio-oncology patients?
If there is a divergence between the biomarkers and echo report, then only we do.
Then only.
Cardiac marker?
Yeah.
Give you a cardiac MR to give a volumetric analysis of
Yeah.
the
And you have to see that software is there in hospital. They do a T2 mapping of extracellular volume and all.
So rather than going for MR, would we have 3D derived machines right now? So the comparable EF can we get, we can get a 3D derived EF
From
also.
the 3D. Okay.
Yes.
Why don't you treat heart failure?
Sorry?
Why don't you treat its cellular dysfunction and keep continuous therapy which
So
cures cancer?
I'm asking because just now the paper was shown that permissive cardiotoxicity in that. So I wanted to ask all the 3 cardiologists at this particular point of time, asymptomatic patient, would you advise about the beta blocker and ACE inhibitors? In asymptomatic patient also you would start that.
Yeah, ACE inhibitor, beta blocker, definitely.
ACE inhibitor, beta blocker.
We are supposed to treat all 4 pillars of heart failure suggested by ESC in this patient and continue therapy which cures cancer.
Yeah, in symptomatic heart failure,
It's
sir.
not the cardiologist to decide to stop therapy. It's just cardiologist is supposed to support cancer therapy which will cure cancer.
Yeah, sir, 4
So
pillars
these
are
patients-
4 pillars
pillars
are
are
only
the-
for symptomatic heart failure.
No.
We are talking about
we are
asymptomatic.
Yes, but we are giving a drug which is again going to cause more LV dysfunction. And LV dysfunction is perpetual condition and there is no return. Even if you use all the pillars of heart failure, at the end of 10 years, all of them will fail. So there's nothing like really, but this drug is not to cure. So cure cancer. You may have a patient with LV dysfunction, treat LV dysfunction.
So there is a lot of
Continue
scope
treatment.
for India-centric publications now.
Sir,
Yeah,
Pandey sir, since you have a mic, what is your take on this top 2 new biomarkers? There are a lot of, 2025 I came across 5 to 6 papers on this.
ST2 we have been using, and Galactin-3 is supposed to be the best one out of all the 3.
Okay.
NT-proBNP, ST2 and Galactin. Galactin is
So this particular patient, sir, would you
most
advise
important.
before starting beta blocker and ACE inhibitors, okay, let's do ST2, SST2 or Galactin-3 marker?
So in asymptomatic LV dysfunction, we do a parametric imaging. Either you do a combination of biomarker or you do a T2 imaging looking at the ECV and transit time. So it has to be parametric, can't be based on just 10% drop in
Just
EF.
out of my curiosity, the way we have liver function tests which covers bilirubin, protein, SGOT, PT, SAP, do we have any lab giving cardiac biomarker which covers all these? No.
Two things is available. LALPath does ST2 and NT-proBNP. Galactin is still in research phase.
Okay. Yes, sir. I can hear you, sir, but I think your mic is not working. Yes, sir. Mic.
See, when we talk about this 10% drop, it's not exactly 10% drop in EF. It's 10% point.
Correct.
So 55 to 45 or 47 to 37. So it's not 10%. Whereas when we are talking about GLS, it's a 15% from the baseline. So this shouldn't be confused. Yeah.
Perfect. I think, sir, last 20 years, for us, ejection fraction is like bread and butter for deciding trastuzumab, but we are moving away slowly further from that. This particular patient, we did not start beta blocker, ACE inhibitors. I felt that this particular patient was absolutely fine. We skipped 1 dose. Echo after that picked up from 50 to 54% from 3 different cardiologists. We started trastuzumab, Phesgo again. Echo before each dose for next 4 doses of Phesgo, normal, and we did not do anything. I don't know we did the right thing. Should we have started ACE inhibitors or beta blockers? That was there. And this particular paper, which was presented earlier, showed that if you give ACE inhibit cardioprotective medications in combination, there is very little cardiac death, and dapagliflozin is phase 3 trials have started. We will come to know about that. So protocols are there for asymptomatic patients, and there are good papers on that. This is something which I came across, and what I did was went back and did card talks of all 3 patients, and it found that it was helpful. Now retrospectively, I could say it was helpful. The last paper in last 2 minutes is low risk, cardiac safety of reduced cardiotoxicity surveillance during HER2 targeted therapy. And this was, I think, presented by Dr. Niyanti, you? No, the low risk was presented. So in that low risk paper, what they said, can we reduce the cardiac surveillance? Okay. So let me ask Dr. Partha Roy. We are doing 3 monthly right now in asymptomatic patients. Would you reduce that in any particular subset of
yes,
patients?
in especially
Dr.
when you are
Munna
going.
Das sitting beside you would say, "Kya बार-बार 3-3 महीने में इको कर रहे हो यार?"
When we are especially going away of anthracycline-based regimens, particularly when we are using both pertuzumab, trastuzumab, in that scenario, especially patient does not have personal history of any cardiac
So in
disorders.
anthracycline, you would
Yes,
not
yes,
deviate
yes,
from
yes,
this thing,
yes.
but assuming patient has not taken anthracycline, would you reduce your duration of surveillance?
Yes, it can be done. It can be.
Dr.
Provided,
Nihanti?
provided patient does not have any personal history of.
Frequency, sorry. Dr. Nihanti?
Sir, I may be wrong, please do correct, sir, because when I was reading this, they do say that if patient is not in risk, even a 6 monthly cardiac surveillance is acceptable.
I'm asking that only.
So,
because so far I am not doing 6
like,
monthly.
yeah.
Any of the audiences, because in trastuzumab we are doing 3 monthly. मैं तो patient को बोलता हूँ calendar में 3-3 महीना डाल देना और आ जाना मेरे पास. This is what we normally tell. So this particular patient, Dr. Niyanti is right. They took 3 main, no cardiac illness of whatsoever kind, no diabetes and no hypertension. And they did 6 monthly, and they found that 0 patient developed symptomatic cardiac event and 1 developed asymptomatic drop in LVF. So I think we can adopt this particular, it's a possibility of reduced surveillance. All CDK4/6 inhibitors are cardiotoxic. This is, please remember that trastuzumab still remains the most cardiotoxic. Reduced surveillance is a possibility. With that, my time is also up, and I close the panel. If any of the panelists have any comments, we can take that.
Sir, I have one query to ask. I'm so sorry, sir.
Go ahead.
Sir, it's the same, sir. If a patient is low risk, upfront patient was not symptomatic, but if there is a drop, can we prophylactically start? Because currently we do have
that is-
ASCO guidelines of ARB inhibitors
That
in
is what sir is saying, and that is what the safe permissible paper showed, the meta-analysis of 8 papers, that if there is a drop of more than 10%, you start with ACE inhibitors or beta blockers or combination of both, and you have a permissible cardiotoxicity comparable to someone who does not have a drop.
Sir, and there's one more take also, you need not stop your oncological intervention also, it's mentioned. So are we right in continuing the oncological care?
I showed those slides. There are 7 criteria of continuing trastuzumab in asymptomatic patient with drop in LVEF. In that they have said there is no other comorbidities, patient is asymptomatic, BP is well controlled, 130/80 is what they have written. You have started on ACE inhibitors and beta blockers, and you are monitoring symptoms properly, you can continue trastuzumab.
Can I just make a comment? If
Yes,
that's
sir.
okay?
Sir,
Now is over to Vivek. Mera time ho gaya now. Whenever Vivek permits, we can continue.
Just a comment.
Yes, so just the comments. I think
last by Arjun.
Okay.
Yeah, so I just wanted to say, so one of the speakers did show one of my studies, the HER-SAFE study.
HER-SAFE
So
study.
we are actually looking at something very similar for the metastatic patients on long-term Herceptin. How long do we do the echocardiography? So we are also looking at 6 monthly echocardiography, so our results should be out soon. But again, we're seeing very similar data that the patients are actually doing reasonably okay. So maybe we can push out the duration of the
Absolutely.
interval.
Very good to know. Ma'am, the
So
last.
yeah, so in our clinical practice at TMH, am I audible?
You're absolutely
Yeah.
audible, ma'am.
So suppose like in this particular case, the EF drops to 50%, we do not stop. I mean, we tell the oncologist to continue the therapy. And as Dr. Gopal said, we start with the the cardioprotective agents. If the and basically, if it's a low risk patient and patient's asymptomatic, go as much as you can. Like we have even re-challenged patients with 45%. If they're asymptomatic, give them the therapy and monitor. We don't monitor every month, every cycle. We do it every 2 months.
55% to 45% is more than 20% drop. You still tell them to continue.
55 to 45 is 10.
10% if you say, but it is a 10% drop. But if you say
it is the absolute 10% drop. Please, there is some confusion there. It is an absolute 10% drop. When we talk in terms of GLS, when we say 15%, it is from 18, 15% of 18.
GLS
but
is different.
EF is 10% is absolute value. And if it is even up to 45, if patient is asymptomatic, we support them with the therapy. In fact, patients with IHD who are 40%, old MI, we have even patients have been treated with trastuzumab with robust GDLT.
There are papers of what you are saying, but from 55 to 45% drop, I think.
EF is not a problem, sir. EF is not a problem at all.
20%.
I think
it's a 10-point drop. Let's see.
It is a
10-point drop in EF, 15% drop in GLS. So there is a percentage, and here is the point.
Yeah. So it's always the percent. Absolutely.
Okay, perfect. Thank you so much. Thank you.
Thank you.